Welcome to Module A of the DIERS Online Academy. In this video, we will look at the DIERS iEMG and the question of how to measure correctly. In detail, we will go through patient preparation, measurement procedure, and analysis with regard to post-processing of the measured sample. Before I can start a measurement, I have to select my patient and then click on New Measurement. Depending on the software license, the various EMG modalities are listed under the Dynamic and DIERS iEMG tabs. These usually include EMG, biofeedback, MVC and, if available, treadmill. The EMG selection includes free measurement of desired muscles, as well as performing and creating guided protocols. This increases the level of standardization, which is very important in EMG and simplifies the comparison of different measurements. The biofeedback examination type focuses on giving patients a better understanding of their neuromuscular activation and thus training the targeted activation or relaxation of selected muscles. In addition to the individual examination types, numerous modalities such as the DIERS 4D motion, DIERS leg axis or DIERS pedogate can also be combined with the DIERS iEMG in a targeted manner. In order to present the differences in the workflow of the different modes in this video, we will first perform a measurement in iEMG Pro mode with a sample rate of 2000 Hz. And later a combination of EMG and documentation in normal iEMG mode with a sample rate of 200 Hz. You can change the setting under F3 in the patient archive. After clicking on Start Measurement, I now enter the synchronization. The sensors must all be in the charging station for this. I click on Synchronize and then come to the sensor assignment. This synchronization is only necessary if we are currently in iEMG Pro mode and recording at 2000 Hz. We now start with the assignment of the sensors to the muscle. This means that we are now in recording mode and must first remove the sensors from the charging station. Normally the LEDs will blink for a short moment while the Bluetooth connection is established. Once the sensors are connected to the dongle, they light up continuously. I then select the first sensor. For example measurement, we choose the right and left tibialis anterior. Click on the respective sensor and then assign it to the corresponding muscle. On the right-hand side of the software, we will give guidance to electrode positioning. In this case, I can see here, for the tibialis anterior, I orient myself to the tip of the fibula and the median malleolus and place the sensor about 2/3 up from the bottom towards the tip of the fibula. Before taking care of the electrode application, we first prepare the patient's skin. The first step is not absolutely necessary. A shave is performed in order to remove hair from the patient's skin. This ensures that the electrodes adhere well on the skin even during dynamic movements. The tibia must also be prepared, as this is where the reference electrodes are placed. As a second step, we recommend the use of an abrasive paste to make the skin as conductive as possible on the surface and to remove all possible interfering factors such as fat, oil, sweat, and the skin epithelium caused by shaving. Optimally, this will make the surface a little rough and the skin will be very slightly red. In the next step, we move on to the definition of the electrodes and their positioning. In our sample, we have assigned sensor 2 to the tibialis anterior on the left. To perform the measurement, we need 3 electrodes. We first apply these to the sensor. This is the simplest method in this system. We have 2 electrodes coming to the lighted LEDs and 1 electrode pointing exactly opposite. The latter is the reference electrode. The 2 electrodes that are on the lighted points of the sensor are placed in the direction of the muscle fiber. If we look at our example, we had already clarified that we are oriented to the medial malleolus and the fibular head. Here we should measure approximately 2/3 and 1/3 and then stick the electrodes in muscle fiber direction. Note that the individual electrode positions are mainly based on the definition of the CENIUM study group. Alas, there are several superficial muscles that are missing a clear position recommendation, which requires a bit of logical understanding by the operator. To put this in general terms, if we do not have a very clear definition of where to place the sensor based on anatomical structures, we simply look at the shape of the muscle belly and put the sensor right in the center of it. For this, we need a muscle contraction. To do this, we can move the leg behind the chair cross brace and ask the patient to push hard against it. In this way, we bring the tibialis anterior to a strong contraction, which allows us to feel the cores well. In the maximum width of the muscle, we apply the sensor in a relaxed state. Tibialis anterior is a muscle where we don't need extension cables because we have a bony structure right next to the muscle, which you can easily use as a reference. If we are measuring a larger muscle, we need a reference electrode on a bony point and use the extension leads accordingly. For the vast majority of on and off measurements, it is sufficient if we use the arrangement of electrodes used here. If we want to be specific about the amplitude, it is a good idea to use the extension leads. To attach the electrodes, I remove the protective caps. Before I remove the last cap, I look at one more point that is particularly important to avoid measurement errors. It is about checking the humidity of the electrode. Since the cover is transparent, I can very easily judge whether the electrode is moist, which is mandatory for the measurement. This allows me to reduce errors before starting the measurement. With this outdated electrode, I can see that the electrode is dried out and no liquid can be moved under the foil. This is an extreme case. The electrode should not look like this. Then we measure out the distances of 2/3 and 1/3 already discussed, go into the muscle belly and observe the muscle fiber direction for the application of the electrodes. It is important that the electrodes are close together. This guarantees a distance of 2 cm, which is the standard in surface EMG procedures. Then we make sure again that the position fits with respect to the tibia and attach the electrodes. It is especially important that I press the electrodes on the edge and only then give a slight pressure in the middle. I will show you why in a moment. I do the same with the reference electrode. We will now look again in detail at how the electrode is pressed on correctly. This becomes particularly clear when the electrodes are attached to a glass, as shown here. First I show how it should not be done. If I press with my thumb on the center of the surface of the electrode, you can see how the contact gel presses between the skin and the adhesive surface on all sides. This impairs adhesion and the electrode slips around. The correct procedure is to position the electrode and apply pressure to the adhesive surfaces on the outside of the electrode. Then the contact gel stays centered where it should be. If the electrode is in place and a shift or strong noise can still be seen in the signal shortly after application, light pressure can be applied to the center of the electrode to establish better contact to the skin. Before we can start the measurement, we have to check the signal quality. Basically, this is done when the muscle is relaxed. The signal quality has a wide variety of influencing factors. Among other things, subcutaneous fat tissue can play a role. Furthermore, so-called crosstalk can have an influence. This means that surrounding muscles or muscles that lie under the muscle that is actually being measured are activated during movement, causing an interference signal that influences the overall signal. In addition, motion artifacts can be added. That is, the electrodes may shift on the skin or the muscle may shift with respect to the skin, which may cause the electrode to no longer sit on top of the muscle being measured. There are also several forms of noise. Among them is ambient noise, which can be caused by interference voltages. But physiological noise can also influence the signal quality. This can be an ECG signal, for example, or it can be triggered by the surrounding respiratory muscles. Furthermore, there can be background noise that emanates from the electrodes. The most important tips for reducing these sources of error or keeping them as small as possible have already been mentioned in part. The skin should be prepared accordingly, and the electrodes, if gel electrodes, should be checked for moisture. If cables are used, they should be firmly secured so that they do not dangle around. In addition, the sensors can also be secured with a belt in case of powerful, quick movement patterns. There should be no unshielded power sources nearby, and the mobile phone should also be out of reach. Lastly, remember and eventually type down the individual movement pattern with regards to muscle fiber length. This enables me to set up a standardized scenario which can be reused reliably at a later stage. That is, I should check once more that the electrode is still sitting on top of the muscle belly when I am in the measurement position. Let's now take a look at the live signal. What needs to be checked there? How can I recognize good quality? Generally, you can recognize a background noise at the baseline. This means that EMG signals are stochastic from the ground up. There are positive and negative peaks. These peaks should be below 15, better still below 10 microvolts. Furthermore, offsets of a baseline should be avoided. This occurs, for example, when the electrodes are dried out. Then the EMG signal does not run on the zero line but above or below it. A so-called offset of the signal should also be avoided. This is caused by cable artifacts if they are not fastened properly. The points mentioned are the landmarks by which I can make out the quality. To be able to read the signal better, the software offers different scaling options. By default, auto-scaling is set, which means that the y-axis is scaled to the respective maximum of a muscle or the maximum activation level. In this way, one can quickly identify the level of the baseline and, if it is too strong, intervene and make changes even before the measurement. In addition to auto-scaling, other options are available. One is the side symmetric scaling and the other the agonist-antagonistic symmetric scaling. Both options increase the comparability by aligning the scaling. If scaling is deselected, a maximum of the y-axis of 550 microvolts is set for all muscles. The reset button can be used to reset the respective scaling. After checking for the quality and setting the scaling, in this case to right-left comparison, we can start the measurement. For this, the feet are guided behind the support and the patient is asked to exert a maximum contraction for 3 seconds and then relax. We repeat this 3 times with a short pause. Again into contraction and then relax again. Again a short pause and another contraction. Hold it for a short time and relax again. Hit save to stop recording. After that, you will automatically be forwarded to the recorded samples processing. This has two functions. Firstly, you can check the signal quality again and whether you have measured everything that you want to measure. The second function is the processing of the signal. You can set sequences and landmarks. The first option is to crop the signal or the graphs. This is done with this button to set the start point. If one has recorded irrelevant data at the beginning of the measurement, this function can crop off the beginning. It is the same with the endpoint. You can set it at the end of the signal depending on whether you want to trim the measurement at the end or not. Furthermore, you can define sequences. In most cases, a sequence contains a contraction of the muscle, as I'm going to show here. Find the moment in which the signal rises from the rest signal for the first time, indicating the start of the contraction. Then define the contraction's end when the signal comes back to the rest signal level. That's how I define my first contraction. Then the software asks me to select a name for the sequence. I name it first isometric max in this case, since we did an isometric maximal contraction. I choose this setting in order to apply the sequence to all muscle signals. I can do the same with so-called landmarks. That is, a certain point of interest in the timeline. This does not have to be within the defined sequences. In this example, maybe a very strong contraction was performed. This is where I set my landmark to and name it with first peak. As soon as I confirm this landmark, this marking is adapted to the other measured muscles. Of course, I can define and name minima as well as maxima. These are the common application examples for the landmarks. But also various points of interest within the movement pattern can be addressed with a landmark. I can do this definition of sequences and landmarks not only for all muscles at once, but also for single muscles. For this purpose, there is this button. If deselected, I can define landmarks and sequences for one muscle only. For example, I can define a relative minimum here. We see that this selection is then defined accordingly only for the selected muscle. In the same way, I repeat this also for a sequence by adding a sequence for the tibialis anterior left. If I want to apply the changes, I press Save, otherwise none of the processing will be applied. I can select two more options at the top. I can either show or hide the inserted landmarks and sequences, and I could undo the whole edit by clicking on the Delete button. Why am I setting sequences? Why am I setting any landmarks? It is crucial for the evaluation and the display of the result pages. If I set sequences and landmarks, I will get corresponding result pages. If, for example, I measure the same muscle on both sides, I also get separate result pages for this depending on the defined sequences in which I can evaluate a right-left comparison much better. The same applies to the agonist-antagonist comparison. If no sequence had been defined, there will be no such a result page afterwards. That is why this step of the analysis is very important. I can decide how to proceed with the measurement using the functions at the bottom right. If I am dissatisfied with the measurement's quality, for example because an electrode has slipped or the background noise is too high, I can delete the measurement. Alternatively, I can continue the measurement series and take another measurement but in a different modality. Then I click here and I'm redirected to the patient archive where I can select the appropriate examination type and start the next measurement. Another possibility is that I continue measuring with the same examination type and am then forwarded directly to the sense assignment, which enables an optimized work process and no unnecessary loops in the software. To end the measurement or the series of measurements, there is a button in the bottom right corner that reads out the memory and displays the result. After clicking this, a pop-up appears prompting the user to reconnect the sensors to the sensor station. Once connected, the sensors will appear with a blue frame on the screen and the Read Memory button can be clicked. Depending on the number of measurements and the length of the recordings, the readout will take a moment. When the readout is finished, you will be directed to the results automatically. In the following, we will take a look at the measurement process in iEMG basic mode, that is, the recordings with a frequency of up to 200 Hz, and we will demonstrate the use of extension cables. First, the question is when and why to use the extension cables. To decide whether or not to use an extension cable, I need to think about two things in advance. First, how large is the muscle area? Can I place the reference electrode next to the muscle? If not, it is recommended to use the extension cables. To do this, it is best to look at the two settings again. In the last setting we had the electrodes attached directly to the sensor. This means that two electrodes form the recording point on the muscle and the reference electrode points in the opposite direction, normally placed off the targeted muscle or on a bony area. This setting comes with a severe spatial limitation. If we want to measure a large area muscle, such as the gluteus maximus, it becomes difficult with this setup because the reference electrode cannot be placed away from the muscle. To be free in the placement of the reference, we use the extension cables. More important than the question of the size of the muscle is the question of what I want to get out of the results. Am I looking at whether the muscle is on or off, or whether one muscle is more activated than another, such as in a side or agonistic-antagonistic comparison? To answer these two questions, it is sufficient to use the somewhat simpler setting where the electrodes are attached directly to the sensor. However, if we want to determine and evaluate the most accurate amplitude or voltage possible, we should use extension adapters even for smaller muscles. In this setting, the calculation of the signal is not disturbed by the activation of the target or an adjacent muscle. We now select the examination type. In this example, we now measure in the combination of EMG and documentation camera. This has the advantage that we can not only view and analyze the EMG signal afterwards, but also make a statement about the movement quality. After clicking on Start Measurement, we already notice the first big difference to the DIERS iEMG Pro mode, namely that no synchronization is performed. We are immediately directed to the sensor assignment and can assign our sensors to the corresponding muscles. In this case, we select the vastus medialis and vastus lateralis of the right and left side respectively. We perform the measurement with 4 sensors and in basic iEMG mode. We now take out 4 sensors to be able to assess the condition of the thigh after knee surgery, in which we check the medial and lateral vastus. The sensors are assigned. For these muscles, we now apply the extension cables. We need the sensors and the cable, and we plug the two pieces together. When this is done, you can see that the cables lead away from the blue LEDs and should then be attached to the muscle cores with the clamps. The skin is prepared so far, both for the points of the muscle and the reference point. Next, we attach the electrodes. For this, we look at the anatomical landmarks, which is the medial condyle of the knee and the ASIS. Approximately 80% from the ASIS is the optimal measurement position or electrode position. We also check this with a palpation and contraction and ask the patient to perform a contraction for this, which makes the vastus easy to palpate. It is important to pay attention to the course of the muscle fiber when applying. The vastus moves approximately in vertical direction, which is why I attach the electrodes in this position. It is also important here that the electrodes are pressed on the outside first. Also, the electrodes should be positioned directly next to each other. The reference plate is attached to a bony point for which the software recommends the malleoli. However, we can also choose the tibia as a bony structure. We need an adhesive ring for attachment, which we apply on the back side around the aluminum electrode. Before we apply the sensor, contact gel, in this case an abrasive paste, must be applied. Not too much, so as not to cover the adhesive surface. Then the adhesive strip is peeled off and the whole thing is stuck to the skin. And then attach the cables to the electrodes on the muscle. Then we ask the patient to let the leg hang relaxed before we start the measurement. In the meantime, I have attached further sensors to the vasti laterali for the postoperative lateral comparison between right and left. From the fact that the sensors light up green, you can see that we are in recording mode. That is, we are already getting the live signal transmitted and can check the signal quality. Then the recording is started. The patient is asked to extend the leg, hold the position for 3 seconds and then slowly return the leg. After a short pause, the movement is performed again. Slowly go into extension and hold on for 1, 2, 3 seconds and return. The movement is performed a third time. Slowly go into extension, hold for 3 seconds and return. When I save the measurement series by clicking on Save, I am automatically forwarded to the data processing. Basically, I have the same editing options in the analysis of a combination of EMG and documentation as after a single measurement with EMG only without the camera. However, there is a big advantage here. I can use the control panel to start the video by clicking play and view it in parallel with the EMG signal. In this case, I have taken a measurement with 4 sensors and scroll up and down to view the individual muscles. The advantage this gives is that I can define sequences more easily using the video. I can pause the video and select Define Sequence. As soon as I move the mouse over the EMG signal, I see how the blue bar follows my movement, and on the right side the corresponding video image to the EMG signal is displayed. I can select the exact moment when the movement sequence starts and set the start point here. I set the end point accordingly at the end of the movement. Then I click on Apply and thus have a precise definition of the sequences based on the video. Finally, I end the measurement series and remove the electrodes and gel residues from the patient's skin with a cloth and some disinfectant. This completes the measurement and I can take a look at the results. This was the video that dealt with the question, how do I measure correctly with the DIERS iEMG? I hope you have learned something and will tune in again soon.